Hi, I'm Dr. Forest-Lam. Welcome back if you've watched our channel previously. And if you're new, welcome also. Um, as we mentioned last time, our future format will be uh, geared towards someone who is getting ready to take the ABIM exam for the first time or recertifying exam likewise. The time frame that I want you to have in the back of your mind, the right kind of urgency is 10 days. You got 10 days more to study for the exam, so you want to not waste a lot of time shuffling paper. You just want to get you good use of your time. Today we're going to talk about peptic ulcer disease and GI bleed. The ligament of Treitz anatomically divides upper GI bleed that is proximal to this anatomical structure from bleeds from GI bleeds that is distal to this structure. Swallow cameras and endoscopes have led to diagnosis of diseases much more distal than before. Now, images uh, as far as the terminal ileum can be visualized. Despite of all the advances, however, about 15% of the GI bleed remain cryptic. The antrum of the stomach contains pyloric glands. Pyloric glands contain D cells, G cells, and goblet cells. D cells secrete somatostatin, which inhibits gastrin secretion. G cells secrete gastrin, which stimulates acid production. Goblet cells secrete mucus to line and protect the stomach from corrosive injury. The stomach, fundus, and body contain parietal cells, which secrete hydrochloric acid, and chief cells, which secrete pepsinogen, which is converted to pepsin by hydrochloric acid. Pepsin can damage the gastric epithelium. Vagus innervation resulting in release of acetylcholine, which leads to stimulation of the proton hydrogen proton pump, the ATPase, and acid secretion. Gastrin release leads to direct stimulation of proton potassium ATPase, leading to acid production and secretion. Histamine release leads to stimulation of the CAMP, which which so the histamine release leads to stimulation of the uh, adenylase cyclase, which leads to CAMP, resulting in stimulation of the hydrogen proton ATPase, resulting in acid production and secretion. Regulation of acid secretion. Basal acid secretion is mediated by vagal tone, highest level at night. The food smelling, uh, food stimulated phase um, has two phases. It's cephalic phase, that is the sight, smell, taste, stimulate vagus nerve. And then there's a gastric phase, triggered off by gastric distension, protein digestion caused by food entering the stomach, followed by gastrin being released. And then there's the intestinal phase, triggered off triggered by protein in the small bowel. Peptic ulcer disease causes direct mucosal injury caused by toxins, alcohol, NSAIDs, H. pylori, bile, inhibition of the inhibition of the prostaglandin synthesis, um, disruption of the protective mucus layer caused by NSAIDs, H. pylori, and increased gastric acid secretion, for example, H. pylori and gastrinoma. Hypercalcemia, sepsis, major sepsis, to CNS and burns can cause peptic ulcer disease. Mucosal ischemia can also cause peptic ulcer disease, for example, in anastomosis ulcers. Um, Most patients have normal acid secretion. Gastric ulcers are associated with a 2 to 4% of malignancies in the individual. Duodenal ulcers rarely represent any underlying malignancy. The lifetime prevalence of peptic ulcer disease is about 1 in 20. The most common symptom is epigastric pain. About 1 in 5 peptic ulcer disease patients have hematemesis, coffee ground emesis, hematochezia, or melanoma. Perforation happens in 1 in 20 peptic ulcer disease patients. 1 in 20 perforate. Exam often reveal rigid abdomen in the case of perforation, rebound tenderness. Duodenal ulcer corrode posteriorly to the pancreas, causing elevation of the lipase and lipase and amylase. This is the one that kind of can confuse with the pancreatitis. Um, Gastric outlet obstruction, usually caused by pyloric scar formation, presents with abdominal bloating, nausea, vomiting, and weight loss. Diagnosis of peptic ulcer disease. Endoscopy has been the gold standard in the diagnosis of PUD. Barium inferior alternative only when endoscope is not possible. Treatment of peptic ulcer disease, antacids, magnesium, and aluminum hydroxide compounds can be toxic to patients with renal failure. So, magnesium, aluminum, be careful when someone has renal failure. Calcium carbonate antacids can cause milk alkali syndrome. So, calcium milk alkali syndrome. I think that the association is what I see in the exam sometimes. And treatment, H2 blockers, not used as much these days as it is um, it is inferior to the proton pump inhibitors. Um, However, H2 blockers work fast, less than an hour, effective for both duodenal and gastric ulcers. H2 blockers t- um, inhibits the tachyphylaxis with long use. So these H2 blockers, after a while, they lose the effectiveness. Cimetidine, worst offender of the P450 drug metabolism problem. It needs to monitor level of drugs closely. So very seldom people use cimetidine anymore, tachymet. Occasionally, the association is it can cause gynecomastia, which is cimetidine seldom use it nowadays. So drugs, this may be a board favorite. What level can the use of cimetidine alter phenytoin, theophylline, and warfarin? Okay, PPIs, the purple pills, the patients will tell you. Omeprazole, pantoprazole, etc. Irreversibly block hydrogen potassium ATPase in 3 days to a subtotal blockade. Um, PPIs increases gastrin level. PPI most effective given before meal PID. PPI is effective for both gastric and duodenal ulcers. Can interfere with absorption of other drugs, ketoconazole, iron, ampicillin, and digoxin. So that might be a question. But PPI increased usage over year has surfaced up negative effect of the PPI, which include hypomagnesemia, decreased mineral density, um, the increase in community-acquired infections, C. difficile infections. It's been suggested that people who take clopidogrel should limit PPI to pantoprazole, rabeprazole, and lansoprazole, or dexlansoprazole. By the way, as you probably know, the manufacturers named these tongue twisters purposely to so you instead of sounding like you speaking foreign language, the only way to really speak like English is to use the brand name. So there's a um, so there you have it. I remember the first word in the English language that starts with ABC is abscissmide. I think they call it Rio Pro for a reason. So instead of saying, "Oh, give me some abscissmide," they'll say, "Give me some Rio Pro." Anyway, omeprazole and esomeprazole, as compared to other PPIs, have greater effect on the CYP2C19 mediated conversion of clopidogrel to its active metabolites, limits its effect on platelets. So it's one of those things you just got to remember. What clinical relevance is a CYP2C19? That's just one of those things you just have to remember. It's like just like with the cease, uh, just like all the other things that just you just have to see it once, and there may be questions on this. I suppose one way the board can ask you about this question is which purple pill can you not give to somebody who's taking clopidogrel, or maybe why, because of the CYP2C19 mediated conversion of clopidogrel to active metabolites, limiting use of its use on platelets, omeprazole and esomeprazole. So if a patient is taking clopidogrel, take the patient off it. Don't think about using omeprazole or esomeprazole. Anyway, PPIs do not have the risk of increasing gastric cancer. It can be associated with rebound acid hypersecretion upon cessation, however. Okay, sucralfate. It stimulates endogenous prostaglandin and stimulates the endogenous prostaglandins and turns on mucosal defenses and repair. That's how sucralfate works. Sucralfate more efficacious for duodenal ulcers than gastric ulcers. Not so effective for gastric ulcers. Avoid using sucralfate in renal insufficiency because of the potential for aluminum toxicity. Duration of use for sucralfate: 4 to 6 weeks for duodenal ulcers, 6 to 8 weeks for gastric ulcers, and EGD and biopsy to rule out gastric CA if you're going to use sucralfate for gastric ulcers. Helicobacter pylori infection. Helicobacter pylori is a gram-negative spiral-shaped flagellated rod. Not flagellated rod. Um, is found in most cases of peptic ulcer disease in the U.S. is found in the mucus layer. It's equipped with urease, which splits urea into ammonia and bicarbonate. Humans are the primary reservoir of H. pylori. Mode of transmission is developed is thought to be fecal oral and or oral. Infection thought to occur in childhood. It is thought that nearly one half of the population near 60 years old are infected. More commonly found in developing countries. So maybe the developing countries have higher incidence of this. Risk factors for H. pylori infection include low socioeconomic status, domestic crowding, and poor sanitation. One half of the world is infected with H. pylori, but only about 10 to 20% of these infected people have GI symptoms. H. pylori tests. Endoscopy is the gold standard for diagnosis of peptic ulcers. Barium studies have good sensitivity for diagnosis of ulcers, but smaller ulcers and erosions may be missed. Barium studies do not allow for specimen sampling. So, barium study, you can't do sampling. Um, but endoscope you can. Serum H. pylori antibody testing is the cheapest non-invasive test with a sensitivity of about 85% and specificity about 80% for diagnosis of H. pylori. So, so you have your H. pylori antibody test, cheapest, non-invasive, 80, 85, 80%. Uh, sensitivity, specificity, respectively. The antibody remain positive for over a year after eradication of the infection, and therefore cannot be used to document successful eradication of the organism. So you don't rely on that to the elimination of the antibody to to guarantee success of treatment. Still, H. pylori antigen tests has a 95% sensitivity and 92% specificity for diagnosis of H. pylori. Uh, it can confirm eradication of the organism. Rapid urease assay, for example, H. pylori-like organism tests and histopathological examination of the endoscope, uh, but may be falsely negative in patients on PPI therapy. So urease tests may not be that good to do if someone who's on PPI. Carbon labeled urea breath testing is the most accurate non-invasive diagnosis with sensitivity and specificity of 95%. So carbon labeled urease breath test, 95% SNS. Commonly used to document treatment success. So if you have uh, H. pylori infection and you do a carbon labeled urease breath test and it's negative, then you're cured, so to speak. Treatment. Triple drug better than two drugs. Reinfection is rare. Resistance to clarithromycin has been observed. If amoxicillin, uh, clarithromycin plus the PPI fails, the second line treatment generally consists of quadruple treatment with bismuth combination. Bismuth, metronidazole, tetracycline, and PPI. So, so you have treatment failure due to resistance of clarithromycin, then you want to go to a one with four uh, four drug combination. So you have bismuth, metronidazole, tetracycline, and a PPI. For penicillin allergic patients, treat with PPI, bismuth, metronidazole, and tetracycline. H. pylori is present in 70% of patients with gastric ulcer and almost all of the duodenal ulcers. So H. pylori is expected to be found in almost all duodenal ulcers, but only 70% gastric. H. pylori is associated with active chronic gastritis, gastric adenoma. Anyway, H. pylori is associated with active chronic gastritis, gastric adenocarcinoma, and MALT. No, this is not the kind you drink. This MALT stands for mucosa associated lymphoid tissue. Mucosa associated lymphoid tissue. So H. pylori is associated with chronic gastritis, gastric CA, and MALT. NSAID associated gastric toxicity. About 15% of the patients who take NSAIDs have dyspepsia and epigastric pain. Mortality rate for patients who have to be hospitalized for NSAIDs related GI complication is 6 to 9%. 6 to 9%. About 1% of the patients who use NSAIDs for arthralgia will have GI bleed. Even baby aspirin use can increase the risk of GI bleed. Enteric-coated aspirin has a similar rate or complications as non-enteric-coated aspirin. This point seems to be widely accepted now. So enteric-coated does not protect like it should. Risk factors include history of ulcers, high dosage use of NSAIDs, advanced age, concomitant use of corticosteroids or anticoagulants. H. pylori is controversial as far as causing uh, NSAIDs-related GI bleed. NSAIDs are acids and can migrate through the protective layer of the mucus to the gastric lining epithelium, where they will associate into the ionized form. The disruption of this mucus allows further injury by gastric acid and pepsin. Inhibition of prostaglandin synthesis is the most damaging aspect of NSAIDs GI complications. Management: stop NSAID use, start PPI, treat H. pylori if ulcer is present. Prophylaxis is not indicated. Misoprostol, a prostaglandin E derivative, has been shown to decrease the incidence of NSAIDs-related ulceration. Diarrhea is a common side effect of misoprostol. Misoprostol is contraindicated as it can be abortifacient during pregnancy. Now the board really loves these. This is a high yield. Just remember this. Don't give a pregnant woman that. And if there's one thing that the board wanted you to know is that don't give abortifacients and teratogens to a pregnant woman. So misoprostol is one of them. Of course, you know the common one is ACEI. You don't give that either. But anyway, H2 blockers Misoprostol is uh, a misoprostol. Stay away during pregnancy. H2 blockers are inferior to PPIs and misoprostol in the treatment of ancest-related GI bleed. Diarrhea is a common side effect of misoprostol use. Eradication of H. pylori if the test is negative before NSAID use and has a history of peptic ulcer disease. Cyclooxygenase 2, COX2 selective inhibitors less likely to cause PUD than COX1. Again, cyclooxygenase 2, COX2 selective inhibitors are less likely to cause peptic ulcer disease than the non selective NSAIDs. However, they lack cardiovascular protective effects. So, all COX2 selective inhibitors appear to have cardiovascular risk that may be dose dependent and should only be used with caution in patients with cardiac risk factors. The protective effect of COX2 selective inhibitors is lost when the patient is on aspirin, even baby aspirin. ZE syndrome, Zollinger-Ellison syndrome. I was told one time that the incidence is about 1 in a million, but we always talk about it as if well, we have to look for a ZE. So it's caused by hypersecretion of gastrin from tumors rise, arising from pancreas or wall of the duodenum, gastrinoma. ZE, Zollinger-Ellison syndrome, presents with peptic ulceration refractory to treatment. Ulceration can be solitary or multiple, involving stomach, duodenum, and jejunum. Diarrhea results from high volumes of gastric acid. Steatorrhea, probably from inactivation of pancreatic enzyme gastric acid from the duodenum. 1 out of 2 gastrinomas are malignant with metastasis to lymph nodes or liver. 1 out of 3 gastrinomas occur as part of the MEN1 adenomas of the parathyroid gland with a hypercalcemia. And the pituitary can be seen. Uh, the gastric acid output is typically more than 15 milliequivalent per liter, and the gastric acid is less than 1. A fasting serum gastrin level off any suppression uh, for at least 5 days serves as a screening test in patients who make gastric acid more than 1,000 picogram per liter is seen in 90% of the ZE patients. So fasting serum gastric level without any suppression for these 5 days serves as a screening test in patients who make gastric acid more than 1,000 picogram per liter, uh, and this will select in 90% of the ZE patients. When gastric serum level is elevated, but less than 1,000 grams per milliliter, a serum stimulation test can show paradoxical increase in gastrin level after IV administration of secretin in patients with gastrinoma. And that concludes our talk. Thank you.